tasked to talk on stillbirth and maternal mortality rates. I try to restrict myself to the African continent, but some of them will appear general. So stillbirth, the birth of child can bring a lot of joy to most of us. However, the sudden demise of a baby or sudden death of a baby could cause a lot of trauma amongst the family and within the community. So it is in this light that I think it's a very important topic with maternal mortality rates. So I took notes from a publication by Smith and Fretz in 2007. And I think the information here hasn't changed that much. So most of my notes were from this publication.
All right.
So the definition of stillbirth is complex. It differs from country to country. And I've just made it simple. So for the purpose of today, we'll describe stillbirth as the death of a baby between 22 weeks of gestation till the delivery time, which shows, that means it shows no signs of life. And signs of life here includes the heart rate, fetal movements, pulsation in the umbilical artery or the cord, if I want to be simplify, and then also breathing movements. So stillbirth accounts for 60% of all perinatal deaths, and the perinatal period is a period from 22 weeks of gestation and 1 week after delivery. So stillbirth includes intrauterine death, that's been death in the womb, and also death after 1 week after delivery, so which is perinatal death. So out of these deaths, 60% are made up of what? Stillbirths. Stillbirth can be classified in various ways. I think there are over 32 or 30 classifications, but I just took the common ones to simplify things. So stillbirth can be classified into early stillbirth, which is death from 20 to 28 weeks, and also late stillbirth, which is from 28 weeks onwards. Okay. It will also be further classified into antepartum stillbirths. That means before the establishment of labor, and intrapartum stillbirths. That means baby is alive, and during delivery, the baby passes on. Okay. What are the causes of stillbirth? They are numerous. We can't list all the causes. If not, we'll be here the whole day or whole night. It's already evening here. So stillbirth, the causes could be from maternal causes. That means a maternal condition that can predispose the baby to death, and also fetal causes. That means that conditions of a baby that can lead to its demise. So the most common ones are associated with fetal death from fetal causes are birth anomalies, or what we call congenital anomalies, which could include anomalies of the heart or cardiovascular, renal anomalies, and some chromosomal anomalies, and musculoskeletal anomalies, and deformities of the CNS or neural system. We also have the fetal-maternal hemorrhage and isoimmunization, and here we're talking of the rhesus factor, where the mother is Rh negative. So this, I'm going a bit technical here, and the baby is positive. So it means that for that particular pregnancy, part of the baby's blood could enter into maternal circulation, and maternal blood will produce antibodies that could cause hemolysis of the fetus. But this does not affect the current pregnancy, but the subsequent one. So that could cause anemia of that baby, and it may lead to its death. We also have other causes like separation of the placenta before delivery, which we call placenta abruption, and placenta previa, which causes also bleeding. Low birth weights could also predispose the baby to death. and we also have cord prolapse. And maternal conditions could include preeclampsia, high blood pressure in pregnancy, and also conditions like infection and diabetes. So if you look at the pie chart here, I usually like the pie chart is easy to interpret. It is true that most causes of stillbirth are unknown. So here unexplained, that means that we can't find any cause. Then we also have small babies. Then others include fetal anomalies, which I mentioned, preeclampsia, which means that high blood pressure with clotting in maternal urine, which is a very fatal condition if not properly managed. Then we also have fetal maternal hemorrhage and other mechanical cause, maternal and miscellaneous. It means that others. Okay. Is someone in?
Hello? Do I go back?
No. I heard someone trying to talk. That's
Yeah, I
why.
just muted. She just joined and then muted. Yeah. Go ahead. We will have our questions at the end of the presentation, so people should just prepare their
Okay,
questions.
I'll just try to. Yeah. So when the baby dies, we try to investigate. However, we are also limited, and sometimes there are challenges in trying to identify the causes of stillbirth. So as I indicated earlier, the definition differs from country to country. It makes it impossible to have a specific data because in other countries, what is termed as stillbirth might not be termed as stillbirth in the next country. So it's really difficult to have a uniform data on this. We also know that in certain parts of the world, couples or mothers reject autopsy because they don't want to cause any disfiguring of the baby after it has been born, because autopsy involves cutting and investigating. And death certificates are also issued before the completion of investigations. Some investigations can take up to 6 months to 1 year, which I've witnessed. So sometimes before it comes, the death certificate has already been signed and the cause of death is not usually completed rightly. Next.
Okay.
So let's compare stillbirth in developed world against low income or developing world. So the fact that you are in a developing country or low income country means that you are likely to have a stillbirth. Sometimes nature predisposes us this way, which I call the social determinants, or what is known as the social determinants of health. Globally, 27% of all stillbirths occur in the third trimester. So if you look at the data and statistics, so in developed countries, it is less than 1 stillbirth per 1,000 deliveries. However, if you come to our part of the world, it's 1 in 100, which means that 10 in 1,000. That is a very big gap. Many deaths are preventable with adequate obstetric care. In sub-Saharan Africa, you have malaria, syphilis, HIV. So that means that if prevention is well managed, then you can help to reduce the incidence of stillbirths.
Okay.
So what are some of the risk factors that could predispose us to stillbirth? So some of the risk factors, first-time mother. So being the fact that you are a first-time mother, there's a risk that you could have a stillbirth. Advanced maternal age, above 35 years, there's also a risk of what? Stillbirth. Then we also have obesity, smoking.
Sorry. Yeah, go ahead.
Obesity and smoking, we call them modifiable risk factors. It means that there's something we can control. So if you are obese, it means that you should try to reduce weight before getting pregnant. And if you're a smoker, you try to stop. If you can't stop, reduce it to the minimum. So that means that they are modifiable. We can influence those risk factors. The status of your education can also predispose you, because The higher you are educated, the more you are likely to read and understand and know what is good for you. And racial disparities, being Black in USA or America predisposes you to stillbirth. I think the stillbirth in the Black population there is about sevenfold more than the white population. So
I will come back to the racial disparities because it's interesting for me. But for now, we can go ahead and then finish this part.
okay. So
And please, for our listeners, if you would have any questions, just put them down and then you can ask at the end of the presentation of all presentations, or you can put them in the chat space so that it will be read out along the line. Thank you very much. Please go ahead.
Okay. And before I continue, if Esther and Gerard would like to add anything or if they would like to correct me, I'll be more than happy to open up and so that we can have a fruitful discussion as we are all in the same field.
Yeah,
Thank you.
so I mean, I agree with you. Along the line, if something they want to add something, they are very welcome to add any other information. But then you would finish your presentation first.
Okay. Next slide.
Okay.
So here I've tried to map the risk factors common in developing countries that causes stillbirth as against developed countries. So we see that in developing countries, the most common ones are obstructed labor or prolonged labor. Then we also have infections like syphilis and HIV/AIDS. Then we have hypertensive diseases like eclampsia, preeclampsia, poor nutritional status or malnutrition will also predispose one to stillbirth. And the fact that you've had a previous stillbirth could also mean that the next one could be a stillbirth. So there's an increased risk. Then we have congenital anomalies or congenital malformations, malaria, and sickle cell disease. Next.
Sorry.
So in developed countries, you see that the risk factors here are limited to congenital malformations, chromosomal anomalies, growth restriction, medical diseases like diabetes and renal diseases, and then hypertensive diseases, which cuts across all populations, and congenitally acquired infections as well. But here we're talking of a special type of bacteria called group B streptococcus, and smoking and twin pregnancy also predisposes to stillbirth. There's a high risk because still every twin pregnancy is considered as a high risk pregnancy where there's a risk that one baby will die and leave the other. And if there are three, it even becomes more complicated.
Okay, how to prevent? Yeah.
So basically there's no prevention for stillbirth because majority of them are unexplained. So I've tried to simplify it here to say that we can prevent something if we know the cause. So prevention depends on the cause. And here we have a lot of causes. So for instance, it is good to risk assess every woman in the antenatal clinic. And in that way, we can manage them very well. So I think that if we're able to identify risk patients, and in most hospitals, all these risk patients will come under consultant-led care, and delivery will be planned differently from a normal pregnancy. So first of all, classify them into or identify the risk pregnancy, then we take it from there. We could also advocate for improved surveillance during pregnancy, during labor and in pregnancy. Like in most developed worlds, we'll use the CTG, which is fetal monitoring of the baby, to check fetal well-being, access to health care, so antenatal care. WHO advises at least, I think, 4 times antenatal care in pregnancy in all. But you find out that in Africa and sub-Saharan Africa, a lot of people do not have access to health facilities and antenatal care. Thank you. So that's the first part of my presentation on stillbirth.
Okay. Thank you very much. I'll come back to you to talk about this, right? But before then, I would let my co-host um, present or talk briefly about the CS aspect, and then we will allow Dr. Gerald to come in, and then we'll come back to you. So I will stop sharing my screen for now. In the meantime, we're trying to be as less technical as possible, because our audience are, let's say, lay people, and we want to communicate in that regard so that they can relate and make some points out of this. And I really appreciate the presentation so far. I was going to, for example, ask about preeclampsia, and you explain it that way. So when I come back, all the technical issues, I would try to ask my questions, and then if there is any need for clarification, you can clarify for us in plain non-technical terms. We good?
We go. Sometimes it's difficult, but we'll see.
I know where it's difficult, we would understand, but if it's possible, then you can let us know. All right, Wendy, over to you.
Good evening. Good evening. My name is Wendy, and I'm the co-host for tonight. I'm a nurse.
At
I'm a nurse in a village.
All right,
Okay.
actually, okay, so let me tell you this. I think that my motivation and our motivation to organize this stemmed from some conversation or post that I have seen from Wendy on her Facebook. She's very popular. She's doing philanthropy work and a lot of other things. And usually she takes time to support kids who have challenges and their parents and all that. And then I saw a conversation between her and a man claiming that women are lazy when it comes to CS and stuff. And this conversation did not end there. I read a post on Silent Beats. Silent Beats is kind of a page for talking about relationships and stuff. And people, there were some men who were agitating against women undergoing CS and giving some weird excuses and reasons why the women are doing that. And then also on Tell It That. So actually, I must say that this program is organized by our group, Wendy, and then Tell It That. On the Tell It That page, there was a post that a doctor, and they have allowed me to talk about it, so that's fair. There was a post about a doctor recommending CS for a client because they said the child was breech or something of the sort, but the husband was asking for, I mean, possibility to what they will call natural birth, like, because the wife had undergone one CS already, and it's like the woman was scared to undergo a second one. And the responses that were going on all suggested that people really need a lot of education and a lot of information on this. So I spoke to administrators of Teledad. I spoke with Wendy, and then we agreed to come up with this discussion to educate the public on this. And as you can see, most of the people are not the people in the medical space, and that's why we asking for more practical and also less technical presentation. Yeah, so Wendy, that's a little bit about you and more
Yes,
about
yes.
other things. So please carry on.
Yes, thank you, thank you. Good evening. Um, I think we are next. We are Dr. Gerard Osei is next. Doctor, we want to go to our next question. As he rightly said, there's been a lot of issues concerning CS. I've personally dealt with a lot of people as a nurse for over a period of time. Because I work in a village, we get to, there are no demarcations with this is the maternity side. Yes, they have the units, but we get to collaborate and take care of all the patients. So, and then also because my inbox is open to a lot of women and a lot of men, we've had a lot of conversations running around cesarean session. So I would want to ask, what are some of the factors that are considered for vaginal birth or a cesarean session? Like, what qualifies a woman to, in quotes, qualifies to say that this one you need a cesarean session, this one a vaginal birth will be unsafe? Because there are instances where we've had to explain to women. I'm sorry for the background noise, it's my dog. We've had to explain to men that even some pelvics and will not allow a woman to push. We've had to explain to men the presentation of the placenta, like the first Dr. Riley said, are equally problems. Like you said, someone was breech. That is the presentation of the baby. So, doctor, if you could tell us, what are some of the things that qualify someone to have a vaginal birth, or say that this patient needs to go through a cesarean session? Thank you very much.
Okay, thank you. So that maybe in my presentation, some of these questions will be addressed. If they are not, then during the question time, I take those particular questions and answer them specifically.
Yes, please, you can share your screen and then go ahead with the presentation.
Okay, so Wendy, so I hope in the course of my presentation, I'll answer that question, and if any further question arises, I'll address that. I don't know if that's okay with you.
Yeah, she's muted, but she said yes.
Yes, doctor. Sorry, I said yes.
I have a question for Patrice. So Patrice, you mentioned one of the factors or causes of stillbirth could be poor nutrition or malnourishment. And this way, it might sound weird, but I want to know if it's on the part of the mother or on the part of the baby, or both, and in what way will this contribute to stillbirth, as Gerald tries to fix himself. And Ines, you can prepare in case Gerald's situation will still be that bad, then you would please come in with your topic before we jump on him. Yeah.
So when you talk of malnutrition, you cannot separate the mother from the baby. So
Mm-hmm.
basically, the mother's body at that point is the provider for the baby. So the state of the mother's health status will indirectly or directly affect the baby. So if the mother has poor nutritional status, it means malnourished. She has anemia, which could be a sign of malnourishment. Then it means that there will not be enough blood flow to the baby as well.
Oh, okay.
And
That makes sense.
if the mom is malnourished, it means that she's predisposed to, she can easily have an infection. And if she has an infection, then it may affect her baby as well.
In essence, we are saying that also the health status of the mother, sorry, the nutritional status of the mother can affect the immunity of the mother and the baby as well, right? That's why it can be easy for a poorly nourished mother to attract disease, which might in turn affect the child, right?
Exactly.
So I don't know, but I would ask the nurses and the midwives, how do you guys, I mean, I know that you are not in the homes of the mothers and you are not providing the funds for food, but do you give any counsel, any advice to this during is it, I don't know, maternity care or antenatal care or whatever it is. But Wendy, you can probably help me
Yes,
correct it.
yes, it's antenatal care. Since
Okay.
we have a midwife on the platform, if she could kindly help us with a question, Miss Inez, if you could, yes, if you could kindly help us with the answer. How do you educate pregnant women on nutrition? How do you check if they are getting the required nutrition and if their nutritional values are up to standard to enable them carry the pregnancy full term?
Yes, great.
Okay, thank you. Thank you for the opportunity. So just as Dr. Patrice mentioned, nutrition plays a crucial role in every human being's life, even before a woman gets pregnant. So the whole conversation about nutrition does not necessarily need to start after a woman has gotten pregnant. The most ideal thing is to start educating a woman about nutrition during what we call preconception. So everything that has to do with a woman's nutrition, her weight or body shape and all of those things needs to be dealt with appropriately even before the woman gets pregnant. That way, we prepare the woman's body to have enough reserve to be able to give to the baby when she eventually gets pregnant. So as much as preconception care is not something that is very popular in our setting, when I say setting, I mean in Ghana, it's still something that we try to provide education on as and when we come into contact with women who are within the reproductive ages or who are within the ages where they are likely to get pregnant. Now, as much as we are not able to deal with the preconception part of things, once a woman becomes pregnant and starts antenatal clinic or antenatal visits, then the midwife ensures that this woman receives the right education, is also counseled to be able to get adequate nutrition. In cases where the woman is unable to meet these nutritional requirements and needs extra help, then the midwife needs to work in collaboration with other providers. And so sometimes the help of a nutritionist or a nutritionist is sought so that this woman can be counseled. So you would realize that in our setting, for instance, in Ghana, certain food groups may be quite expensive. So in your education, you try to educate the woman to be able to get these nutrients from sources that are easy to come by. For instance, you want to educate women to eat from all the food groups, at least eat their 3 square meals a day and still be able to get some snacks in between, because now they are having to feed 2 human beings, as people would usually say. But you also want to educate this woman not to overeat, so that, because the thought of saying that, oh, you are feeding 2 human beings can mislead some people to just overeat, maybe end up eating like 5 times a day. So you want this woman to eat 3 square meals and have snacks in between. And when it comes to the snack, you want to encourage healthy snacks. For instance, you want to tell the woman maybe seasonal fruits, the fruits that are in season can be her snack. So in between her meals, she can have 2 oranges or a mango. And then this way, she's able to build her energy stores as well as nutritional stores to be able to provide for the baby. Then when it comes to the food groups, you want her to eat her carbohydrates, you want her to eat her proteins, you want her to eat her vegetables, which will provide her with the needed vitamins and micronutrients. And to add to that, we also add on some micronutrients in the form of medications, such as folic acid, iron supplementation, because we believe that sometimes the way we prepare our meals also makes us to lose some of these nutrients. And also because we also don't get enough, we are able to complement whatever the woman gets through food with these micronutrient supplementations that we give. So that's just a little bit about how we go about nutrition. Even these days, we have what we call pregnancy schools, where in some areas you actually find midwives teaching women how to prepare their meals, just so they don't lose a lot of nutrients from the food that they eat. So just a summary of how we provide nutritional education and counseling in pregnancy. Thank you.
Thank you.
Thank you so much. Is doctor ready? Can we?
Yeah, is my screen
Yeah, your
visible?
screen was showing until about a few seconds ago, but now we can hear you very clearly. So just show your screen and go ahead, please.
Okay. Is it showing now?
Yes, it is.
Is it showing?
Yes, please, it is.
Okay. So thank you for the opportunity to talk about such an important topic. And I think the organizers have done very well combining or linking stillbirth to cesarean section for us to know the need for that. You know, childbirth is very significant event. It's a very significant event in everybody's life, especially the females, the families and country as a whole. And we know for childbirth, it can just go the natural way, just as Enoch was mentioning. That's the vaginal route or the medical intervention, where we call cesarean section delivery. But we know that while many deliveries, a lot of deliveries will be uncomplicated, meaning that they can go through the normal vaginal route. There are certain instances where the pregnant woman will need a cesarean section or medical intervention for the delivery, for a safe delivery of a healthy baby and a healthy mother. So cesarean section is a necessity. We should get that from the beginning, not to satisfy the clinician or the medical professionals' desires or any other thing. It's a necessity to deliver a safe mother and a safe baby. So cesarean section is actually a surgical procedure where a baby is delivered through an incision or a cut on a pregnant woman's abdomen to deliver the baby through the womb, as we will say, where a vaginal delivery or the natural route will not be feasible or safe for the mother or for the baby. There are certain indications, reasons why we will suggest cesarean section for a pregnant woman.
Good.
I'll just mention the common ones. We have certain reasons which is pertaining to the mother. For whatever reason, the mother has a condition for which the mother or the woman cannot deliver through the vaginal route. And for such conditions, we will suggest a cesarean delivery for that pregnant woman. And some of these reasons are, one, because of what Enoch said. I'll talk about the previous cesarean session, a pregnant woman who had already delivered via or through a cesarean section in a previous pregnancies. For such pregnant women, based on the weight of the baby at the time of delivery, it will inform the clinical or the medical professionals as to whether the mother can deliver safely or not. Because you should keep in mind that this woman has already delivered via a cesarean section. It means there's a cut, a scar, a healed wound on that womb. So that side of the womb is not as strong as the other side. So if this child to be delivered is expected or estimated to be big, and we know it will not be safe during the labor, when assuming we want this woman to try the natural route, we know it predisposes this pregnant woman at risk of that side or that scarred uterus, that particular point rupturing or bursting, to put it in layman's term, because the healed part is not as strong as the other part. And we know it is common that instances where that side will rupture or break is very common in pregnant women who have already delivered before, and the current pregnancy, the baby is estimated to be big. Big meaning in certain countries they will say 4 kilograms, but in this part of the country, Ghana, we normally use around 3.5 kilograms. If the baby is estimated to be more than 3.5 kilograms, we would say it is not safe and we will suggest cesarean section to this pregnant woman. And my colleague also talked about the placenta position. If the placenta position, we know normally when women are delivering through the vaginal route, the baby's head comes first. So assuming the placenta in this current pregnant woman we are talking about, who is about to deliver through the vaginal route, the placenta is ahead of the baby. Meaning, if the woman is supposed to deliver through the vaginal route, this placenta, which is feeding the baby, will come out, and it has a lot of blood in it, will come out before the baby. If the placenta should come out before the baby or during natural labor, it means this baby this mother is going to bleed a lot, and which can lead to the death of the mother. So we would suggest, and we normally get this before delivery, because throughout the scan we can tell the location of the placenta, and we'll suggest cesarean section for these. The previous speaker also talked about preeclampsia. That's high blood pressure in pregnancy with associated effects on certain organs in these pregnant women, and certain infection. And the most common one here is when a woman is going into labor and we notice the labor is not progressing, it's not going on as expected. We will say there is a poor progress or obstructed labor. And this is normally sometimes found in very big baby, a woman with a small hip, meaning that the baby size and the hip of the mother does not correspond. The baby's size is bigger than the hip of the baby. When we see that, we can tell the labor can be a bit difficult, and we wouldn't like such a pregnant woman to go through the normal vaginal delivery. But in case it comes in normal labor, we've estimated and think this woman can deliver through the vaginal route. But in the care during labor, we notice that labor is not progressing, it's not going on as expected. Then we'll suggest cesarean section for such a pregnant woman. We also have certain fetal, the baby's condition, for which we will suggest cesarean section for a mother who is about to deliver. Assuming during labor, a pregnant woman is in labor, we monitor the baby's heart. If the heart is beating very well, assuming in the process of labor, we check the baby's heart and it's beating too fast or too slow, we have a range. We say normally 110 to 160. It should fall within that range. If it is below that or above that, we'll try some resuscitation, meaning we'll give some medications, some positions to see if the baby's heart will come back to normal. If it does come back to normal, labor continues. But after all these interventions, if the baby's heart is still not as expected, we will suggest a cesarean section, because it's a well-controlled environment. It can go in as fast and get the baby out of that stressful situation for which the heart is not beating well. If the baby's position, just as I said, normal labor, vaginal labor, the baby's head is supposed to come first. But assuming this time the buttocks or the legs are coming before, that's the breech presentation. In certain instances where we have a well-experienced midwife or obstetrician, we'll try, and the baby's weight and everything is fine, we'll try and deliver this baby who is coming with the buttocks through the vaginal route. But in certain situations where we think we don't have the expertise at the facility you are delivering to do the breech delivery, the facility or the health professionals may suggest a cesarean delivery for such a pregnant woman. And when there are twins or triplets, multiple pregnancies, the health professionals may also suggest a cesarean section for you, all to deliver a healthy baby or babies and a healthy mother. And we have some obstetric complications that's throughout the labor. When the woman is delivering through the vagina, things can go wrong, for which we would suggest cesarean section. I know more questions will come. I've just summarized it into these three groups. Yes.
Mm-hmm.
Yeah, so we have some complications of childbirth for which we will need the cesarean section. I've mentioned, I've just itemized them. This is just a few of them. And my brother, I know, will be talking about maternal mortality. In 1990, Ghana's mortality rate was around 760 per 100,000. So it was said that about in every 100 deliveries, 100,000 deliveries in Ghana, about 760 of these pregnant women will die, which is very scary.
Let me calculate the percentage, but continue.
Which is very, very scary. But we know for some interventions, the mortality rate has gone down as of 2015 to about 300 about 319, but which is still not up to what WHO recommend for us as a developing country. WHO is estimating about 70 or less mortality per 100,000, and we are currently as a nation at around 319. It means we have more work to do. And just as my colleague also who presented earlier said, that it's because of some difficult access to cesarean sections and some obstetric care. That's why we have a lot of this stillbirth. So if we are able to manage that aspect very well, we can at least reduce this mortality rate, because CS has come to help in a way. Currently, as a nation, our average cesarean rate hovers around 13%, which also literally means that every when we take about 100 women who are delivering, 13%, 13 of the 100 women will deliver through cesarean section in Ghana over here, as in the whole nation as a whole. That's averagely. But we have specific facilities, like my Kolebu's cesarean rate is around almost 40 to 50, between 40 and 50. Tama General is also around the same rate. And these are centers where we refer other smaller hospitals refer pregnant women to. So it means they would have tried something at the peripheral facilities. So when they bring them there, it's sometimes kind of urgent and we need to deliver them. And the best way we could do that to get a safe mother and child is via a cesarean section. There are lots of different types of cesarean section. We have some that can be planned, assuming we know the baby is way bigger than what the mother can, or the mother has undergone 2 previous cesarean section. We can plan that, at maybe when the pregnancy gets to 38 weeks, we'll do a cesarean section. That's a planned cesarean section, which is called an elective. We have some emergencies that will have to deliver the baby or the mother immediately to save both the mother and child. We can make a very transverse incision on the womb, or vertical incision, which I don't think I should stress on it. Every surgery comes with its own complication, for which we counsel the couple or the pregnant woman before we go for cesarean section. So if you've noticed, every cesarean section, the pregnant woman signs a consent, accepting that I have agreed that you should deliver me through a cesarean section. And if any relative or a husband is around, they make them sign as a witness. And in this consent form, we tell you all these complications that can come, that the incision site where we make the cut can get infected. During the procedure, you can bleed a lot. And during the process of getting the baby out, there can be a cut on the baby, or the leg can break when we are extracting the baby, which the fetal risks are very low, very, very low risk, but we have to tell them before we go ahead. Against the fact that if we do not do this for you, the likelihood of not getting a healthy baby, or the mother getting to a serious complication or even dying, is high. So we have to weigh the advantages and disadvantages of the cesarean section. But all this, we still have to tell the pregnant woman and their family before we take them for the cesarean session. From what Enoch talked about, I thought it's wise to just talk about just some few of the myths of cesarean section delivery, and try and explain it in layman's terms using a medical reasons, so that
Doctor, sorry,
Okay.
could you hold on to that? That will be one of our
Okay.
major discussions.
Okay, fine.
Yes, exactly.
Okay, then
I
I'll
would want
hold.
you to really dive into that later, because that's
fine then.
part of the reason why a lot of people have been joined.
Okay, that's good. Then
Thank
I think
you.
for now, I think with this, I think I can hold my presentation for now, and if the opportunity comes, we'll talk about the myth associated or the common myth about cesarean section. Okay, thank you very much.
Thank you very
Thank you.
much, Doctor. Thank you so much. I've taken a lot of notes. I know we said we are waiting. I know we said we are waiting to ask the questions later, but there are two questions I want clarification on.
Okay,
When you were mentioning that of the reasons why a mother would, in quotes, qualify for CS. When I say qualify, I
okay,
mean it's a candidate for CS. You
okay,
mentioned when there is a severe lung or heart disease. Maybe I as a nurse, I understand why when a mother has a lung disease, she would have to go through CS. But let's say to the lay person who doesn't understand why is it that when someone has a lung and a heart disease, the person is indicated for CS? That's my first question. And then kindly
okay.
clarify for me on the Kolebu, you said 40 to 50%. You specifically said it's because it's a referral center. I just wanted you to
Yes,
hammer that part so that
yes,
people would
yes,
understand that it's because
yes.
it's our biggest hospital in the
Hospital.
country. Thank you
Yeah.
very much. So if you could kindly address my first question.
Okay, so for the women women with heart and lung diseases, we know during labor, it's a lot of it's a stressful situation where stressful environment where the woman uses a lot of energy, a lot of the heart pumps a lot of blood to the uterus for that process of labor to be successful or peaceful or uneventful. So assuming a pregnant woman who is known to have maybe, let's just say, let me take asthma, the lung condition. Let me just take an asthmatic pregnant woman who's been having a lot of asthmatic attacks throughout the pregnancy. Maybe a week before she even came to she came to the labor ward to deliver or labor sets in, she had a severe asthmatic attack. We wouldn't like this woman to go through labor through the normal vaginal route because natural labor takes a longer time. It can spread to as far as even 12 hours. So assuming this non-asthmatic who had recently had an attack comes into the labor ward to labor, we wouldn't like her to go through that stress because she will need a lot of naturally during labor, the pregnant woman needs a lot of oxygen, needs a lot of energy, and this is already an asthmatic patient who finds it difficult just recently, a week ago, to breathe. We wouldn't like her to go through that stressful labor, which can compromise her life and the life of that baby. So that's for the lung. Another pregnant woman who is known to have a heart disease, maybe a heart disease with even a pacemaker. It has something artificial to support her heartbeat very well. We wouldn't like this woman with a pacemaker to go through normal vaginal delivery because we know natural labor is very stressful, which will overload the heart during that period, and the heart can give up. That can lead to a very detrimental outcome for the labor. So these are some of the reasons why we wouldn't like people with heart and lung conditions to go through normal labor. But before then, I should be quick to say that before that, any known pregnant woman who is known to have a heart or lung disease will be asked to see the cardiac specialist, the pulmonologist, to assess if she is fit enough to go through that stressful situation before we we advise whether she can go through normal vaginal delivery or we suggest cesarean section for such a pregnant woman. Thank you.
Thank you very much. So, Doctor, basically from what you said, cesarean sections are medical interventions.
Yes, they are. Yes.
Thank you very much.
Yeah.
Thank you.
I stress on
Thank you
that.
very
Yeah.
much. Thank you very much. We have another doctor who just joined. There is another specialist who just joined. His name, I can mention the Dr. Caesar, but Dr. Caesar, if you can hear me, I wouldn't
Yes.
want to get your name wrong. So if you
Yeah.
could kindly introduce yourself so that at some point I can direct some of my questions to you, especially when it comes to the myth
Yeah.
surroundings here. Doctor, can you
And
hear me?
Yes,
I
I
think,
can. Am I clear?
yes, please.
Yes,
But
you are.
before then, Gerald, please, can you for now stop sharing so that we can see our speakers on screen? Yeah,
Okay, thank you.
great. So Dr. Caesar Awunsobo or something like that. Please, you have the
Yeah.
floor.
So,
Doctor, kindly introduce yourself.
You can show your video as well.
sure. I'm Caesar Awanboro
I
Anson.
won't borrow. Okay.
More like
Thank
I
you,
won't
doctor.
borrow. I won't borrow Anson.
I won't borrow. Okay, doctor.
Yes,
I
please.
didn't want to get your name wrong, so that's why I wanted you to introduce yourself. Thank you so much, doctor, for joining. I'll be directing some of our questions to you specifically because I had to quickly go through your profile. Doctor, could I ask where you practice?
I practice at a Tamale Teaching Hospital as well as
Great,
Thank
Havana Medical Service.
Thank you
great.
very much. I intentionally asked that because I've encountered a lot of women, specifically, not to say, not, how do I put it? I've encountered a lot of patients from Tamale, from the north, and then they also have a lot of myths surrounding cesarean section. That's why I asked where you work, because I'll be directing a lot of those questions to you, because I'm sure you've encountered a couple of them.
And roadmap, yeah. So Patrick's hands is up, but let's Patrick speak and then we can go back to him. Yeah.
Yeah, so I
Okay.
wanted to also acknowledge the presence of Caesar, but you've already done that. Caesar is my direct cousin. I didn't know he'll be on the show as well.
Ah.
Oh, okay.
So it's
Great,
So,
great.
good to
so
see
he
you.
commented on my post, and then I unofficially invited him.
Oh,
That's
okay.
good.
That's great. That's great.
In a part of the world, uh, prenatal is not something that is very common. We barely see anyone. We barely see women walk to the hospital and say, "I would want to learn more about my body, learn more about childbirth. I'm trying to prepare to have a baby." We barely see that. So could you kindly tell us just something small about prenatal, and then you take us to the role of antenatal, and then how our midwives help us when it comes to our pregnant women from conception to labor to successful delivery of the baby, and then aftercare of delivery. Thank you.
All right. Thank you too. Thank you for the opportunity once again. So for midwives, like I said, the role of a midwife ideally should start from the preconception, where a woman is educated, her body is prepared, and the right things are told to her. And she also does the right things and gets her body ready for pregnancy and childbirth. However, because we don't get a lot of that happening in our part of the world, so the midwives' work usually would start from the antenatal. And so we have what we call the first booking. So the first time a woman comes into contact with a midwife, the midwife would need to register the woman as a pregnant woman who is starting antenatal. And antenatal is very, very important because it is during that period that the woman and the baby would receive the care that they need. They will receive the right education. The midwife will also help dispel some myths that a woman may bring to the hospital and be able to guide her to make some birth-related decisions. And so I have here a few things that midwives do when it comes to the antenatal, and I will talk about them under various headings. So for the first thing that I have, we have screening. So we have what we call antenatal screening. And so when a woman comes to the antenatal, the midwife would need to first of all check her vital signs to be able to detect any abnormalities. The midwife will also need to go ahead to request for some labs, depending on where the midwife finds herself. If you are lucky to be in our urban areas where antenatal care is sometimes obstetrician-led, then you have the obstetricians prescribing the labs. But for women who find themselves in the rural areas, sometimes in our peri-urban centers, you realize that the midwife will request for some labs to be able to check the woman's blood levels, to be able to check some existing medical conditions or sexually transmitted infections, just to be able to detect a baseline for this woman, because this baseline will be able to give the midwife the roadmap of care to plan for the woman. So the screening is done to be able to give the roadmap of care, as well as to have tailored education for the woman. The midwife also does a complete history taking. So it takes history of the woman's pregnancy history, childbirth history, takes a holistic history of maybe any previous surgeries, whether birth-related surgeries or not. You take those histories. You take history of any pre-existing medical conditions, take some family history as well, some social history, including drinking and smoking history, to be able to provide education. Okay, so the history is also taken to provide a baseline as well as guide the plan of care for the woman. And then midwives are also, because most of the care we have in this country is midwife-led, like that's the first person you come into contact with when you come to antenatal. It is the midwife's role to actually detect early any problems that the woman may have. So from the history that is taken, from the screening that is done, the midwife will be able to detect early any problems or any anticipated complications, and be able to collaborate with other healthcare team members to plan appropriate care for this woman. The midwife is also supposed to monitor the woman and the baby at every antenatal visit to be able to detect any abnormalities, because the fact that a woman started antenatal with normal vital signs, with a good history, and other things mean normal, does not mean that things cannot change at any point in time during the course of the pregnancy. So it is the midwife's role to also provide adequate monitoring as well as education, so that even when the woman is not in the hospital and is at home, the woman can also identify any danger signs at home and be able to report to the hospital for care. And we also have escalation. So during the antenatal, when a midwife detects any problems or anticipates any problems, it is important that the midwife refers the woman to a medical doctor, an obstetrician, or whichever cadre of doctor is available, so that they can collaborate and plan the care for the woman. Then referrals. So for midwives who find themselves in primary healthcare facilities, for instance, health centers, CHIPS compounds, because sometimes these days, some polyclinics have theaters and have doctors. So if you find yourself in an environment where there's no doctor, once you anticipate any problems or you anticipate that a woman may have any challenges pertaining to the pregnancy or the childbirth, it is important to refer early to the appropriate center so that the woman can get able to meet the needs they're able to have. Now, when it comes to midwives giving education and dispelling myths in antenatal, it is very important to be very culturally sensitive, because different people come from different places, and where they find themselves can influence the decisions that they make during the antenatal, whether it's good for them and their babies or not. And so in giving education or providing women with education, it is important to be very culturally sensitive. You need to tailor your education to meet the cultural needs of the people. For instance, if you are giving education to a pregnant woman who comes from an area where they don't believe that they have to eat eggs or snails during pregnancy, you need to be very sensitive as you deliver the information. And you also need to be very informed yourself, so that beyond the eggs, beyond the snails, what alternatives can you provide for this woman? Sometimes you can also have some community engagement with opinion leaders and the people who matter in such communities, so that you can dispel some of these things on a group basis. Then terminologies also are very important. So you hear people say normal delivery and cesarean section. These terminologies alone can want to choose one option over the other, even when it is not ideal. So sometimes the way we use the terminologies we use is also crucial. So you want to say that vaginal delivery and cesarean section. Recently, I was in a forum where someone said both are natural deliveries. If you really, because at the end of the day, it's not like somebody gives somebody some medication and they cough the baby out. At the end of the day, all of them come together to safeguard maternal and newborn health. So we want to use the terminology so that they also don't end up swaying people to choose one option.
Yeah,
So
actually, Wendy corrected me on this one today, so I'm happy that I didn't say. But yeah, go ahead.
Okay. These are the things that midwives do. They provide holistic care. They collaborate with other people to provide care. They refer when it is necessary, and they ensure that women, babies, and communities are safe. And in doing all of this, midwives are supposed to promote vaginal birth as best as they can. But when there's a need for cesarean section, midwives also come together with a team to make sure that it also goes well. So basically, that's what midwives do. Thank you.
Thank you. Thank you, Miss. Thank you very much for your input. I want to direct one question to Dr. Caesar before we talk about the myth, which I think would take a bit of a period to discuss. Dr. Caesar, please, are you available?
Yes, please.
Thank you very much. So I would want you to tell us more about the legalities associated with seeking consent for CS on the part of the husband and also the women, because there was an argument in my inbox. I'm sure you saw a bit of it, where the argument started from somewhere. He felt like he wasn't even looking on the part of the nurses, but of his wife. He felt like we, the healthcare providers, should give the man the room to have the final say. As in, we are wrong when we allow the CS, in quotes, let me say allow the CS, when the husband says no. That was where the argument came from. He thinks that the husband should be able to have the final say as to whether the woman should go through the cesarean section or not. I wanted to ask, are there legalities? Are there, in quotes, laws governing consent when it comes to CS?
So, when it comes to informed consent with regards to cesarean section or informed consent of any form, we have to look at what informed consent is. So an individual who, on his own volition, voluntarily agrees to an intervention or participates in any procedure. So it means that before you talk about informed consent, there is a voluntary component of it. So the woman should be seen to be willing, voluntarily willing. Now, to administer informed consent, usually you would want to be sure that the woman is having the capacity to be able to give an informed consent. And that is where the legal age of capacity comes in. In our jurisdiction, women above 18 years who do not have any suspicion, for instance, if you have no suspicion the person has a mental disorder or a medical condition that can impair the person's understanding of what you are going to explain to them in the language they understand. So I tell Madam X, you need a cesarean section. Looking at her, she understands me and is able to reproduce all that I've said. So once you realize the person has a capacity, in other jurisdictions, capacity, the legal age is 16 years. But in our setting, we use 18 years. Now, after you have assessed whether a client has the capacity, you also have to look at what information you are providing. So the previous speakers did mention that you should tell the person or speak to the person in a language the person understands, expressing the indication for the cesarean section. Madam, I want to do a cesarean section for you because your baby's heart rate has gone up. and baby is poo-pooing in the water. We call that fetal distress. Now, having told the person the indication, you are supposed to tell the person the progression of your indication. If you do not intervene, what can happen? If you intervene, what can happen? Then you will move on to explain what the woman should expect through the cesarean session. What is she to expect? So there's an anesthesia assessment component. There's a pre-op preparation component by the nurse caring for the patient. There is administration of the consent form. You need to walk them through, including the complications that can be encountered, be it anesthesia, pre-op, intra-op, or immediate post-op, and even long-term. And then you offer them the alternatives, if there is any. Where you have an emergency cesarean, most often you have no alternatives. Having done that, you would also want to tell her, should there be anticipated complications, what are the measures that you, a doctor or a caregiver, what measures have you put in place? For instance, you have a potential, you have a bleeding placenta previa. That's a low-lying placenta that is bleeding. You want to operate. You know that one of the complications is excessive bleeding. And you have told her she's likely to bleed to death. But you haven't told her that you have arranged to get blood for her, or you haven't engaged her together with her relatives to get blood. So all the alternatives, if the woman is a Jehovah's and is going for surgery, you have to tell her, okay, because of your power of attorney, the alternative. So we have hydrating the woman very well so that she doesn't lose so much blood, tranexamic use, like some medications, alternatives. So you need to expel all the options to the person, making sure that the client is following. Afterwards, you will then administer the consent. Now, once the woman is more than 18 years, she has to give you the permission to go ahead. And in administering consent, we should not be seen as doctors or caregivers to be imposing certain indications on the woman. You should not be seen to be forcing the woman. Clearly explain to them the situation on the ground. With the scenario you mentioned, we do not, or per our practice, you don't require the husband to give you consent to perform a cesarean section. It is just out of respect that he came with his wife, you have done your assessment, and you need to inform him that based on the reason they came to the facility, you have evaluated the woman and you think that the best solution is a cesarean section. And then the way you spoke with the wife, you give him the same information, just so that he is in the known. He is then encouraged to witness. If it is an emergency and the husband is refusing to witness, but the patient has signed, if you are a specialist and above, or you are the senior most person on the ground and above, and you strongly think that your indication is well-grounded, you can proceed and perform the surgery to save both mother and baby. Sometimes what we do is that we don't want to go in alone so that when trouble comes, you are left standing. So every hospital has a medical sup. They have a legal team. You need to just draw them in. We have such a potential litigation. But when a spouse starts expressing contrary views, not wanting to sign or not wanting to allow their wives to exercise their rights, you would also need to at least inform somebody superior. But if you find yourself where you have no option, but the woman has agreed, sometimes what I do is that I tell the woman, Madam, you were from a home before you went to marry. And as a professional, this is the best for you. If we do not deliver the baby and the consequences or complications do occur, you are going to feel the grief more than anybody. Can you call someone within your family and at least let them know that this is the situation you find yourself? The doctor says, let's deliver urgently within 30 minutes, but my husband is refusing. I have a couple like that. The wife told me, Doctor, I want the CS. My previous delivery, I had a bad tear into my anus in the United States. And the doctor told me categorically, wherever I find myself, do not try vaginal delivery. But the husband was still insistent. So I told her, you have an indication for cesarean section. But as a couples, keep trying to convince him, but you don't require the husband to sign on the consent form authorizing you to perform the procedure as a doctor. And the last thing is always document whatever transpired. Documentation is very key. And as you are working, you work as a team. You have nurses, you have a matron, you have work as a team so that if even the husband decides to take you on, they are going to look at whether you place the woman in any form of unnecessary harm by way of the procedure or intervention that you did. If the answer is no, and it was your duty to which you carried out successfully, sometimes you go in and you don't get good outcomes. That is where the dilemma is. Because the husband said, don't go in. You went in and complications have set in. But as trained specialists, we are being taught to usually document and make sure that the client understood exactly what she was going in for and sign the consent form willingly, voluntarily. And in the documentation, don't just write, you counsel the person and she agreed. At least break it down to let us all know that you went through all the requirements of informed consent, including death of the baby and the mother. Because sometimes you don't have the control of certain situations or complications. You try your best, but you don't still come out successfully. But the client should always know almost all the complications that can occur. Thanks.
Thank you very much, Doctor. Thank you so much. But I wanted to play a scenario and ask you a question based on the scenario. Doctor, assuming a husband brings in a wife who is, let's say, not conscious enough to give consent, but as an urgent need, the wife needs to be operated on. This is a situation where the wife is not able to give consent and the husband is refusing. And the woman is our patient, but she's unable to give consent. Let's say she's unconscious. She's unable to give consent, but CS will be a life-saving intervention. And the husband is insisting that we should wait until she gains consciousness. In that instance, what can be done?
So what the law so informed consent, let me just go back a bit. There is a historical basis or perspective for informed consent. Whether you are administering informed consent for a research or answer the scenario you gave. And I said that it was or is being guided by the Helsinki Declaration or the Belmont report. And all these are meant to ensure that whatever intervention you are doing is beneficial to the woman and gives the woman the autonomy to always make decisions and causes no harm to the client. So where a husband has brought in an unconscious woman and he refuses consent, you will reach out to any family member. Where you cannot reach out to any family member to get consent, you, the doctor, have the right to go on with the procedure, irrespective of the husband declining. Like I said, get your legal team informed and document and go in. But when you are going in, the question is, whatever decision you are making, is it going to be beneficial? Those are the key words. You shouldn't be seen to be paternalistic, but in being beneficial. Sometimes you have to be paternalistic, especially in this scenario where you are taking that decision on behalf of the unconscious person. So that is what or how to go about such a scenario.
I will
Right.
have
All
a
right, doctor. So you are saying that in such situations, we should prioritize our patients, the greater good. That's what you're saying. Whilst we involve the legal team, we should look at the greater good that we'll be doing and the service we'll be doing to the woman and the baby. Thank you very
Yes,
much,
please.
doctor.
Yeah.
Thank you very much.
Wendy.
You know,
Maybe can we take some questions from our audience to
yes,
make it a bit interactive, and then you can go back to your main questions to the people, yeah?
yes, sure. I even have just my last question. So if anyone has a question, I'm just looking at the chats. My last question, I think it will be a discussion for all of us. The myths around cesarean section. So I happen to work in a typical village setting where there are a lot of religious groups. Even in Christianity, we have divisions. There are people know about the Jehovah Witnesses. They are not against cesarean section. I don't know for some of them. But I work in a community where there's a particular group of people who observe the Sabbath. I observe the Sabbath as well. But they are different from we, the Adventists. And they are vividly against cesarean section because they believe that the Hebrew women, the olden days Bible, they were delivering safely, and then they would even squat and the baby will come out like an egg. And once you're having a cesarean session, you are not praying enough. And doctor, let me address it to Dr. Musa. Let's start with Dr. Musa if he's still online.
Yeah, Patrice is still here, and then Gerard also had some points on it. But yeah, let's start with Patrice.
Yes. I wanted to. Yes, I have a question for Dr. Gerard. I wanted to wait till the end.
All
Doctor,
right.
could you, because they also believe that there is this, when you work in a village, the information centers, those that sell the local concoctions, if I should put it like that, they will say that about the once you have a surgery, you have a cesarean session, once they operate, 50% of your strength is gone. The rest is just what you manage till you die. Doctor, please, when we have cesarean sessions, does it affect our strength in the absence of complications, which can happen even in vaginal birth? But in the absence of complications, when we have a cesarean session, does it reduce, in quotes, our strength and our ability as women, as is being said out there?
Okay, thanks very much. Yeah, this is not true because there hasn't been any research on that yet, and I've not yet encountered anything like that. Cesarean section, yes, the reconvalescent period, that means the period from the cesarean section till the time you are healed is a bit longer than the natural delivery. But in the end, you get healed and you go back to your normal activities. It does not reduce your strength and you go back to what you could do. So it is just a wrong perception. Thank you.
Thank you very much, Doctor. Dr. Gerard, what are some of the myths that you, even as a doctor, have heard, and then you've gone like, hey, this one, it's even a shock to you as a doctor. What are some of them that you've heard that you would want to educate us on, and then we can also intend teach others? Thank you very much.
Yeah, okay. Thank you very much for this question. This very myth we just talked about with reduction of strength, you're not going to get back your strength as before. I was surprised. Because maybe because of where I find myself, where I see a lot of the women undergoing cesarean section, and these same women you just operated on, after 3 months, they are carrying whatever they are carrying on the roadside selling again. So I was surprised to hear another person say it reduces the the strength, their strength, and that go back to normalcy again, normal activities again. So that's one for that. I don't know if you like me to talk about other then or people have questions about the other myth.
Yes.
Yes,
Doctor,
go ahead and talk about
yes, go ahead and tell us some of the ones that you've heard, because we have heard
the
a
one
lot about it.
you
Now they
wanted
are
to
even
present.
saying, it's lazy women who want to go through cesarean section. They say we are not praying enough. That's why you go through cesarean section. Some are saying that once you go through, they are even saying, just in case you've not heard, now they are saying that doctors are encouraging CS because
Of the money.
we are selling the placentas. Yes, we are selling the placentas to these people into cosmetics, and that one placenta is being sold between $50,000 to $500,000, and they prefer the placenta they get from CS because it hasn't gone through the vagina, so it's not been contaminated. Just in case you've not heard. So some of the things that you've heard, yes. So even me. I have 3 kids and I had them through cesarean section. A doctor. At that time, I think he wasn't a resident yet, but he told me that when your child grows, you don't have to tell the child that she was born through my first child. She was born through CS so that she doesn't feel inferior as compared to those ones that were born vaginally. This was said to me, even though I'm a nurse, it was said to me. So if you could kindly address some of those issues for us, thank you.
Okay, so we just have to keep in mind that whatever we are talking about, we should keep in mind the cultural practices and where we find ourselves. And we know there are myths we are trying to dispel. So it's an idea we've been having over the period. We should let them know with evidence and practical situations or events surrounding them for them to appreciate what we want them to understand or to be able to dispel such myth. So I would like to take talk. I think 10 myths about cesarean section I wanted us to talk about, discuss. And the first one is cesarean section is only for women who are weak, which from the indications I gave already, I tried to explain that it is a necessity, not because they are weak. Not because they are weak. If you give birth to, if a pregnant woman is able to carry a very big baby, maybe 4 kg and beyond, how can you say such a woman is weak than someone who is carrying a baby who is 2 kg and about to deliver through the vagina? Even just with that, the stronger people carry stronger things, right? So how can you say a woman who is carrying a 4 kg is weaker than, do you get it? But it's an indication, it's a very necessary reason for the cesarean section. So with that, you can just tell them. I normally tell those I hear saying that it's not true. The other myth is a woman who has cesarean section can never have vaginal delivery, which we know have something we call the vaginal birth after cesarean section. And I told you, if you've had cesarean section and it's more than at least 18 months for you to deliver again. So it means that you deliver via cesarean section and you're about to deliver now, but your last child, or the last cesarean section, or the last child is more than 6 months, 1 year, 6 months. We can let you try vaginal birth, provided the conditions are met. I told you about when someone who has delivered already is delivering, about to deliver a big baby, more than 3.5 for us here in Ghana, but elsewhere, even if the baby is not more than 4 kilograms, you can let the woman who has delivered via cesarean section go through a normal vaginal delivery. And the success rate is very high. So that myth, I think there are lots of people walking around who's done one cesarean section and after that has delivered 2 or 3 vaginal, who have had 2 or 3 vaginal deliveries. Also, the myth that women who have cesarean section cannot do hard work, which I think I have explained. You see people who have delivered and just after some few months, 3 or 4 months, they are back to their normal routines, especially those in the offices. You are only given 3 months maternity leave. You have to go back and do whatever you are doing. And sometimes you'll even be surprised. Some people are even more active after they are delivering via cesarean section than before, because now they know they have to double up to meet their targets. Also, cesarean section and financial myth. I think we'll answer one of the myth you talked about. Some even think cesarean section, they believe it's only for the wealthy people. It's only the rich people who can go do cesarean section, which is not true because for our health insurance scheme, it covers cesarean section. Our health insurance covers cesarean section. And this is even breaking the gap, whether you are poor, rich, so far as you have your health insurance, it should cover your cesarean section for you. If you find yourself in another facility, a private facility or another facility which offers other services, maybe the room you are lying in is not like the standard government facility, but the private hospital takes health insurance, then they will be asking you to top up something or pay for something, not the cesarean section, but you're paying for something else in addition to your bill, but not the cesarean section because even the health insurance covers cesarean section. So cesarean section is not for only the wealthy. Also, cesarean, we say DS is always the doctor's way of making more money. Doctor's way of making more money. I don't know, Dr. Caesar and my other colleagues here said they are in the government hospitals. So this is what I normally tell my patients or the family when they think it's the doctor's way of making more money. So I tell them the government pays us. The government pays us. If we come and there's no case for me to even stand for hours to do a cesarean section, the government still pays me. If the whole week I just do one cesarean section, the government pays me the same amount. If I do 20, the government still pays me the same amount. He pays the midwife the same amount if he does a lot of delivery. It doesn't change that. So if that is the case, what would we prefer? To do more cesarean section or to do less? Because it's not going to add anything. It's not going to add anything to my salary. And the other aspect I would like to talk about with the finances, the myth about the financial aspect is the private sector. You hear this about the private sector a lot, that the private sectors are requesting for cesarean section to make more money. But you should keep in mind that all health workers sign an oath to do no harm, and we have the patient's best interest. Sometimes if you're in a private facility, the patient's best interest will mean that going in for an intervention such as cesarean section, which is more expensive than vaginal delivery. But the reason why we are requesting for the cesarean section is not to make money, but we told you that for the mother to deliver a healthy baby and her herself being very healthy. That's the reason why we will say that. The ethics of our medical practice is to do no harm.
Thank you very
So
much.
in a private facility, so I'll give a practical example why a private facility, if I am in a private facility and I'm seeing a pregnant woman who have had maybe a previous cesarean section, who has had a previous cesarean section, I'm seeing at the private facility. Now, patient is about maybe 37 weeks. And the baby's weight is small. The baby can go through the normal vaginal route. But in the private facility, you might not have the whole surgical team 24/7 in the private facility. But the government facilities the bigger ones might have doctors, anesthetists, and everybody there for the whole 24 hours. So if such a patient is going into labor, and there is a complication which will necessitate a cesarean section, the private facility does not have all that facility all the time. So I will suggest a cesarean section straight from the word go, because I don't want you to get into labor where you would need the service and emergency cesarean section. And because it's a private facility where we are not equipped with the theater and theater staff 24/7, we will suggest cesarean section. And to this, it is fair for someone to stand behind who does not know the details of this to say it's because of money the private facility wants money. It is fair from their point of view until they've been told all this and they still hold on to the fact that it's for the financial benefits. Then I think I would blame such a person. But until then, if they don't know and don't understand, they are free to say that. But I hope that's why there's opportunity like this for us to talk about things of this sort. And some also think that whatever we think pregnant woman will make a pregnant woman need a cesarean section, the traditional medicine people can reverse that effect, which sometimes I am very practical about that. Let's use the same example as a previous CS with a risk scar or a placenta previa. Well, I don't know how the traditional people can reposition the placenta from that low lying very close to the cervix to prevent bleeding during vaginal delivery. So sometimes I try and use images, diagrams to explain to these patients and their relatives, especially their husbands, for them to know why such statements are not true. Also, babies born through cesarean section are not as strong as people or babies that were born through the vaginal route, and there are lots of research to suggest otherwise, provided all conditions are the same for both mothers and babies. Also, a woman's stomach will never be flat after cesarean section. And this, I think the women will also understand, it's the same for, if it's not coming back, then it's just the same as women who also had vaginal delivery. There has not been any correlation between a woman's stomach or abdomen after cesarean section and one that underwent or delivered through vaginal delivery. And also some say that the scar from cesarean section never heals completely. I don't know what they mean by never heals completely. If you are comparing a scarred uterus to a non-scarred uterus, then definitely the non-scarred uterus, meaning that a woman who has not had CS, comparing a woman who had not had CS and the one with CS, definitely the woman without CS womb will be more intact because he's not have any scar or injury or cut on it. But it doesn't mean that the woman who had CS the scar cannot heal completely. It heals completely. And it is said that it is known that after about 1 year, 6 months, the scar would have healed with a very good integrity, for which a woman can undergo vaginal delivery after cesarean section. And finally, I would like to talk about that CS is a curse or a sign of spiritual weakness. And I also think anytime they say that, I also think it's a way of scaring people. And most of the time, the people who come in with this are the men. And what I have noticed is I normally sit them somewhere and find out the actual cost. But sometimes it's because of the little extra money they will pay for the cesarean section, especially even if they don't have health insurance, the amounts they will pay. That's what encourages them to be holding on to this myth, which I think getting more time to explain and finding out the reason why they don't want a cesarean section so that we explain to them better will be a better way. And most of the time, most people accept the cesarean section and they get a better outcome. Thank you very much.
Thank you, Doctor. Thank you so much. Dr. Caesar, please, if you are still available.
Yeah, he's here.
Okay.
Okay. Doctor, so I've heard from some of my patients that in some tribes, in some families, CS is a taboo. And that women in their families are not allowed to go through CS, and that wives that are married into their families are not allowed to go through CS. Please, have you ever encountered such, and how did you go about it?
So far, I've encountered just one case like that. And the woman said in her family, or her sisters, siblings, uncles, and aunts have all had vaginal delivery, and it's a taboo to undergo cesarean section. So when that happened, fortunately for us, it wasn't in an emergency setting. It was, I think, breech. That's a baby not presenting with the head, but she came in at about 39, 40 weeks. We couldn't have done an external cephalic because she didn't consent to it. So the other option would have been a cesarean section, but that was her first pregnancy. So she told us no, she cannot, although she herself is okay with it, but because of the family member she came with, they would not permit her to undergo the cesarean. So my head of department had to reach out to the husband, and the husband had to bring their head of family. So the head of family explained their stance. And we also explained all the options available. The option was to allow her go into labor and then try pushing the baby through the breech position, and the attending complications that can be that can be encountered. The man said he would go home and then consult with other elders. After about 3 days of going, he came back and then asked us to proceed. Apparently, they went to perform some customary rites and then gave us the permission to allow the woman to have the cesarean section. So it's not an easy task, especially if you don't have the luxury of it being an elective where you can always schedule. But where it's an emergency, it's very, very difficult, because once the person does not consent, you can practically do anything. And as for the consent, I remember I was in a community near Doma when I had a Jehovah's abrupt show with a live baby. The woman just told me her wishes. She won't consent. And by then, I was a medical officer. So I called a specialist at Doma Presby Hospital. And he was like, Dr. Hansen, this woman you want to bring to me, will she change her mind if she arrives here? And my answer in my head was no. So the other option was to let her go to the Sunyani Regional Hospital. And from Doma area to Sunyani, you can imagine the number of minutes that is going to take. Eventually, she didn't get a baby, and she herself had kidney complications from the excessive bleeding. Yeah.
Yeah, I was going to ask a question related to that. So if as a practitioner, you think that this is the best option for the client, but the client is not consenting to that, are you at liberty to let them explore other options outside the hospital, or you still have to go by what they want, and if it doesn't go well, what are the implications?
So the client is always at liberty to choose whichever facility she wants to seek help from. It's your duty to make sure that the patient, if it's an emergency, is adequately resuscitated. If the resuscitation involves an intervention and she doesn't consent, then your resuscitation ends at maybe just the IV fluids, maybe just blood transfusions, and then linking her to the facility of choice so that you can make a placing, ask her where she wants to go. Or I want to go to Konfanochi. So you place in a call such that the receiving facility is ready for them, and then they will offer the services. Sometimes what we don't like is you moving from a teaching hospital to
a lesser primary health
yes,
center.
primary health. We usually don't encourage that, because we all know the strengths and weaknesses associated with primary healthcare, because most facilities which are within the primary healthcare system probably do not have operating theaters. They do not meet what we call the emergency
status.
Status. Yeah.
Okay, so Wendy, one more question from me. I want to turn it the other way around. And I think there is a member here or someone who just joined, and she would also agree with me on this question. There was a post, and here the wife had agreed to the vaginal north delivery, and the post was about the fact that the husband wants the wife to go for a selective CS.
Elective
Elective,
CS.
sorry, elective CS. Um, the post really didn't state categorically what the reasons of the
I
husband
can help
was.
you.
Yes,
Let
please
me
go
help
ahead.
you with that.
Yes,
So
go
it's
ahead.
also a myth. I would have asked the question anyway. It's also a
Mhm.
myth that some men believe that when a woman has a baby vaginally, the orifice, like there will be an enlargement of in quote the hole, and which
Mhm.
will make sex not as enjoyable as it used to be. So I've encountered a couple of men like that who just come into my maybe vaginally would she so me I don't want the place to gape. So I would rather she goes through cesarean section so that the place will be tight enough for me. I don't know if any of our doctors would would want to help us with this, considering the anatomy of the body, considering the anatomy of the vagina, if any of them would want to address this
Oh,
for us. And then after this, I go to midwife specialist with my
okay.
next question.
Okay, great. Also,
Doctor, I don't know any of you would be willing to help us.
If Ines can also, if she has also some insight on this, she can
Yes,
take it.
sure. Of course, she's a midwife.
Oh, okay, Enoch and Wendy, thank you. So what I always tell women is that the things that make a woman look young, that makes your breast firm, that makes your body, your skin looks the way it looks when you're younger, is because of the hormones in your body. And the way your skin looks when you're younger is the same way your internal structures also operate. So the vaginal walls, they are made of muscles. The
Mhm.
areas it's the pelvic floor, those are all made of muscles.
Hello,
And
Emma.
all these are controlled by hormones that you have in your body as a woman. Now, as your age advances, these hormones also take a dive. That is why beyond a certain age, a woman cannot have babies. So whether you have babies as a woman or not, once your age advances, your body would also start responding to age. So some women will say, I don't want to give birth because I don't want my breast to fall. I don't want to breastfeed a baby because I don't want my breast to fall. Whether we do this or not, our breast will still fall. It's a natural phenomenon. We can't run away from it. So I'm just trying to use this to relate to the fact that whether a woman has a normal or a vaginal delivery or a cesarean birth, due to hormonal action and the weight of even carrying pregnancy on the muscles of the pelvic floor, there is already pressure, there is already some loss of elasticity in the muscles. What we encourage women to do is what we call some postnatal exercises. For example,
Could you
Kegel
mute those
exercise.
that are muted, please?
For example, Kegel's exercise that helps to strengthen the pelvic floor. So it's not really about vaginal birth or cesarean section, even though sometimes vaginal birth can also come with complications such as extended tears that could go deeper and cause other problems. Sometimes the mere fact that a woman has gone through pregnancy can cause some of these things. So whether you lean towards one option or the other does not mean that a woman's vaginal walls will not lose elasticity with time. Rather, it is more beneficial to help these women with exercises that strengthen the pelvic floor. Thank you.
Thank you very much. I don't know if anyone has anything to add up because we are about to wrap up. And
Okay.
in the absence of any questions from our audience, I wanted to ask doctors if they could, wrapping up, if they have any messages for us, if any advices for us. I'm hoping we could do this another time and, tackle different kinds of
Aspect.
topics
Mhm.
pertaining to women. But I don't know if, let me start with Dr. Baba Musa. Doctor, what are your last words? What are you telling us?
Okay, Wendy, before they come in, so actually, Baba Musa is also into public health education, and
Great.
he has he started some YouTube series, and he presents some insightful topics. So maybe
Beautiful.
Patrice, you can mention that along the line, and also actually,
If he could
I
also
had
share the name with me, and then I will share later on
on
my
your
wall as well, so that we get more audience to.
exactly.
Yeah. Yes,
And
please.
maybe we should agree to come back again at another time so that our audience can follow, because there is also the situation that when Gerald and Caesar and I think, yeah, we're talking, they mentioned about explaining to the client and stuff. And I have understood a lot of times that when you guys tell, I don't know even if if it is the case that you tell them that the possibilities are 50-50, you know, and the mentality that immediately runs in their brain is that, oh, so the person can die or live. And if it is 50-50, why waste the money? And if it's not successful? So maybe, I don't know if time will permit, if you explain in details what you mean by that expression, if you undertake intervention, there is 50-50 chance whether it is about life and death.
You're talking about the consent. Dr. Caesar was saying that in every procedure medically, there are complications.
Mm-hmm,
And then once you are seeking for the consent from the
mm-hmm,
patient or
mm-hmm,
witness, the relative or friend or whoever as a witness,
mm-hmm,
you need to tell them every possible complication that can come with the procedure. Is that the
mm-hmm.
area you are wanting to look at?
Exactly. And
Okay.
then
Okay.
exactly on that. And I don't know if it is really true that the doctors say 50-50.
Well, I can't talk for them,
Uh-huh.
but I know that whilst it's as simple and also as complicated as Dr. Caesar explained. They will tell you the possibility. You see, when he was explaining, I'm just trying to share my experience and thoughts. When he was explaining, he
Mm-hmm.
was saying that there are different reasons that will lead to a cesarean section.
Mm-hmm.
Some are even elective. Some, there are cases where the woman will opt for cesarean section.
Mm-hmm.
So where there is, okay, let's say it's placenta previa. Maybe
Mm-hmm.
this is the possible complication outcome. I don't know if I'm making sense.
Yeah,
So
yes, you're
depending
making
on
sense.
what is leading to the CS, they will tell you which complication is a possibility.
Mm-hmm.
Because there are women that even their type of pelvics doesn't allow them to push a baby out vaginally.
Mm-hmm.
So there are so many instances where they will tell you, like, because this is what is leading to the cesarean section, this is a possible complication. But like Dr. Caesar says, we would weigh the good against, in quotes, the bad. But I'm sure the doctors on there would
And
love to address the
the
issue more.
midwife, yeah,
Yes,
please.
yes, yes.
Also,
And
you
then
can come in.
let's talk with the midwife, because you see, in most of our settings, even where I work, we've never had an
Doctor.
obstetrician. So midwives.
Mm-hmm.
Exactly. So midwives are, most parts of the country, the women see the midwives and all that. So auntie midwife, he wants more light shown on the consent and how we explain the possible complications to the patients and their relatives.
All right, okay. So let me just hit on what he said at first, that's 50-50. I don't think I've ever heard a doctor tell a patient that cesarean section is 50-50. No. Some surgeries, they will tell you 50-50. If you are doing a brain surgery, if you are doing a spinal cord surgery, those things, they can tell you 50-50, but not for cesarean section. Now, just as Wendy said, the complications are explained to you on case-by-case basis. For instance, if you are a woman who went into labor and in the course of the labor, the baby's heartbeat starts dropping or starts beating faster than it should, and at that moment, maybe the water around the baby, instead of being clear, the color starts changing because other things are happening in there that are making the baby get into some form of distress. When you are being rushed to theater, depending on the baby's heart rate at the point in time, the doctor may tell you that we are going in with a 50-50 hope that we'll get the baby or not, but not for the mother.
Okay.
Now, there are other instances where when the woman's life itself is at stake, then the relatives will be informed. For instance, I've had a patient who is a case of, like, he was living with sickle cell disease, and sickle cell patients tend to have some wild complications during pregnancy and labor, especially if they happen to go into sickle cell crisis whilst pregnant or in the course of labor. That can be quite challenging, because if you want to do cesarean section and you want to give them anesthesia, the medication that we give to numb the pain from getting to them, yes, you realize that it kind of further complicates their issues. So in such situations, then we would also say that, oh, we are going in hoping that we can save mother and baby, but there's also the possibility that there may be anesthesia complications. Now, mind you, we are in Africa, we are in Ghana, so we are even more careful what we tell patients compared to elsewhere, where it is easy to just say things as they are. So when it is just cesarean section based on some complications that are not life-threatening to the mother, I've not heard a doctor say 50-50. But if you have the woman's health compromised, maybe she's already unconscious, she's already in a critical state, then that one we can say, yes, we have a 50-50 chance. But that is hardly said, because by the time decisions are made for cesarean section, mostly it's either it's already picked during antenatal and is planned, or even in labor, we are monitoring so well that by the time things go south, that decision is taken. So we don't always put women's lives like at such risk that we are telling them it's 50-50. Because if you tell a woman in labor your CS is 50-50, that's already a lost battle. How many people will consent? So those are the kind of conversations. So we talk to them about the possibility of bleeding, the possibility of an infection after the cesarean section during the healing period, with the bleeding being the most likely complication that we face when we go into theater. And that is also why now the anesthesia that we give is no longer the one that they put you completely to sleep, except only in some situations where a woman is already bleeding before we take you to theater, then there's a need to put you to sleep. But in most cases, they just inject your back and then you are awake. You don't feel the pain, and the CS is done. Thank you.
Thank you.
Thank
Wendy,
you.
have you seen your screen? There is a question, but
Yes.
I don't know if you want to take it.
No, I've seen it, so I would rather the doctors take it. I wanted to add up to what our nurse specialist said, our midwife specialist actually. Some of them, even when you are telling them, she mentioned that maybe the baby is in distress, and that we could say that the pertaining to the baby and how far this has gone, maybe the baby's is, this can be a complication. In our typical Ghanaian society, they would even say, hey, don't use your mouth to say such words. Oh. You should be positive. The relative will be telling you not to use your mouth to be saying, to be making such pronouncement. But this is a situation where you, as a healthcare provider, you're supposed to let the patients know what are some of the possible outcomes. So I'll read the question to our audience, to our doctors, and then let's see if anyone would help us with an answer. Let me read it. It says, great work. I have a patient who has to visit the hospital on two different occasions due to high BP. On the first occasion, it was high BP. She was treated and given medication. Is it a client that is already pregnant? Okay, I think there's a follow-up question. Sorry. On the first occasion, it was a high BP and she was treated and given some medication and discharged. On the second occasion, it was a low BP. The client is unable to sleep, numbness of the feet and hands, inability not to sleep, etc. What is your candid counsel on this, please? And then the follow-up is the client has gone through this situation for her two babies, and she has vowed not to give birth through CS in case she would want to have a third baby. So I don't know if the person asking the question is talking about pregnancy-induced hypertension and how the hypertension reduced after, how the BP maybe came down after the woman had the baby, and I don't know if any of our doctors would be able to help us. Dr. Baba Musa, are you available to help us with this?
Yes, that's okay. Yeah, so we have to take this in perspective. If she was already having the high BP before a pregnancy or it was during pregnancy, but then we need to sort out the problem now. She was put on medication for high BP. I don't know what high here means. And once you put someone on a medication and all of a sudden she has a low BP, it's most likely that you are overdosing her. So the wise thing to do is to reduce the medication gradually. So you could reduce the medication. Better still, in our setting, I will admit her, reduce the medication to make sure that I'm able to get the right balance of dose during the admission. So I'm able to monitor her during hospitalization. If I reduce it and it's still low, then I reduce it further. Within 24 hours or 48 hours, I'll be able to get the right medication for her. So I want to believe that she's been overdosed, and it's better, or it would be good if you invited her and start reducing the medication gradually. Because if you take it off as well, you cause what we call the rebound phenomenon. It's like when you put water in a can and pressurize it for long, and all of a sudden you open it, it's going to flow out a lot. Or if you hold your water hose and you put a lot of pressure, and all of a sudden you release it, you see the way it comes out, and this could cause some stroke. So gradually reduce the medication, and I think that should be the solution.
Thank you, doctor. In the question, she said the woman is saying she would not want to go through CS again. I'm thinking she thinks she encountered the high BP because she went through cesarean section. Could you also say something about that?
Um,
I'm not an expert, but yeah. So, Patrice, before you come in, I think that sometimes they don't tell the complete story. Okay. My wife at the moment is pregnant and she goes for the antenatal in my absence. And when she comes, I want to know everything that they told her, her BP, her sugar and stuff. And maybe on one occasion, her BP was say 35 and oh no, actually she went and the BP was still within the range, I think 80 and then 125 or 124 or so. And the nurse or the midwife made a mistake and wrote, I think the upper one was 138 or something of the sort. And on that, the doctor wanted to admit her until they had to talk seriously about it to make sure that it was a mistake and stuff. And so, you see, the question is about there was a high BP and then went second time and it was low BP. And probably Patrice have spoken about the medication that was used to reduce. How about probably some practices outside the medication that the client is engaging in? Could it be, for example, because of the high BP, this person was also advised to lower the intake of salt and related substances, and as a matter of doing that, it affected the BP so much because I also know people who are hypo how do you call it? They have low BP and they are even advised to take higher their salt intake is higher. So yeah,
Hypotension, yeah.
yeah. How do you reconcile
Hypotension.
the two?
And I don't know where to start from, because I was about answering a question and you came in with this.
Okay, go ahead with the question you wanted to answer. I thought it was part of the question that you were going to answer, but yeah, please go ahead and answer the question.
So yeah, you were asking if this cesarean section was the cause of the BP. I can cause of low BP, I can categorically say no. Sometimes the spinal anesthesia could be a reason for low BP, but that will be detected almost immediately or within her admission. But once she was discharged home, I want to believe that if she had spinal anesthesia, then it shouldn't be the cause. And there's one thing we also usually forget, that some of the women, especially first-time women, don't have enough sleep after their deliveries. And when you don't sleep, what happens? Your BP is going to go high. So it's something that I realized from practice. I usually ask, do you sleep well? Then some of them will tell you, I haven't slept in a week, because they're always scared if they sleep, the baby is going to go missing, or they just get anxiety. So they're always awake in the night. So BP and pregnancy induced can also start after delivery, within the 6 weeks of delivery, especially the first 2 weeks are critical. You can have preeclampsia. So they are within limits, and cesarean section is not the cause of that. So that's
Thank you,
the answer
doctor.
to that question. And
Thank you, doctor.
what Enoch was saying about reduction of, well, first of all, I don't think anyone will admit you for a BP of 138 over what, 80 or 85. Maybe that was just wrong information. And sometimes there could be communication barrier, especially in a country where they don't speak English. So I think that there would have been a miscommunication there, because no one will offer you admission on such. And especially if she didn't have any symptoms as well. And on the reduction of salt intake, that shouldn't have a big effect on your BP. And whether you take salt or don't take salt, it's a gradual process. It doesn't cause acute low blood pressure. So I think it's also a misconception. And I'll be happy if Caesar or my other colleagues can correct me or make any additions. Thank you.
Thank you very much, doctor. Okay, so there's another question. In the absence of, let me see if I can read that for Dr. Caesar too.
Yeah,
Oh, I
that's
think yes, this is not a question, but a contribution, I think. He says education on CS in our part of the world is still not sitting well in the minds of people who have decided that no matter what, CS is evil. The education should be consistent as much as we can. Thank you very much, Esther. We would continue to educate our clients on that. Enoch, I don't know if you have any further questions or
I think we have actually stretched the time a lot, and I feel like
yeah, we've gone over time.
our speakers have
Facility,
really
yes.
done well, and we can
Yes.
free them and go back to the drawing board. And if there will be some emerging questions that needs us to bring them again on board for further discussion,
Yes, yes.
we can do that. So
When
maybe.
next we're able to get there, maybe we can look at infertility because of in recent times too, in my inbox is the concoctions some women are being made to take all
Mm,
in the name of
mm,
trying to conceive, and
mm,
how toxic society has been to them, and how some are developing medical conditions as a result of some of the inhumane things they are made to go through, the
mm.
concoctions they are using in animal and all those things. So maybe when next we are able to bring such brilliant minds on board, we can tackle that kind of topic as well.
Yeah,
Thank you very much.
let's work on that on the background and contact them later to come and help us with it.
Yes.
I think that generally, as a man, I feel that when some of these issues come up, I don't want society to attack it as though men and women are at war, right?
Yes.
I think that genuinely some of these topics or issues are emanating from a place of ignorance. Some are emanating from a place of social
Socioeconomic
idiosyncrasy,
background.
yeah, socioeconomic background, cultural background, traditional beliefs, and all that. So I agree with
Mm.
Esther Joy Cranton King about the education aspect. And sometimes the comments and the reaction of the people makes it so difficult to even talk it through. You know, one man would expose their ignorance and the attack becomes on all men. But see, I am
Yeah.
here and I'm thinking about how to bring experts on board to help to educate both men and women alike. Trust me, I have my own idiosyncrasy like about certain things, but I need some time and I feel like maybe some counseling session and other stuff, and maybe subsequent session we may bring counselors in on into the situation, because with the man who was chatting with you, All
Yes,
he's thinking about is 5 kids. Meanwhile, there is also the possibility that you can go into marriage and there will be no child. And people,
exactly.
when they have not prepared their mind and everything for such, they come in, and if it is not happening, they get surprised and they want to leave the marriage. So there is a lot of work that we need to embark on, a lot of education. And I want to thank our speakers for volunteering their time to educate. Their presentations, their contributions for me were so insightful and very educative. And
Yes,
Wendy,
I've learned a lot.
let's plan and then do more of this. I think it will help the masses, and we would organize it more appropriately than today,
Yes, yes, yes. This is our first time, so we would ask them to forgive us. We went overboard, and I think we will coordinate it better in our next meeting. I would especially want to thank Dr. Caesar. We didn't even pre-inform you about this.
Yes,
We didn't give you the opportunity to prepare. You just out of your own goodwill decided to join. We put you on the spot and asked you a lot of questions, and you were kind enough to explain and teach us. We want to say thank you very much for your time. We want to thank you, Dr. Gerald. We want to thank you, Dr. Baba Musa. Our next specialist, is it Ines? I really don't want to get your name wrong. So we want to say thank you. If any of you has anything to say to us, please, we would love
their
to hear
final
your last
words.
comments.
Yeah.
Yes, your final words on. Maybe we can start from Dr. Caesar. Your final words for
And
us.
please show us your face. We want to do that for you.
Okay, this is my face.
Yeah.
My For my final words, what I would want to um, ask our midwives and colleague doctors, specialists, is to encourage male partner involvement in our antenatal and postnatal care or services, because most of the time the men do not participate. So when the women are getting they are being educated at antenatal or pregnancy schools, they are not there. They don't know the journey, the possible complications. They don't participate in birth preparedness. So when such a man is now told at the last minute that there is a problem, he's taken aback. The pocket is also empty. Like my colleague said, some of the concerns is because of the financial commitment, immediate and then the long term. So let's encourage more husbands to accompany their wives, and some government facilities like Kolebu and Tamale. When you accompany your wife, you are prioritized so that you can go back to your work site as soon as possible. You don't we skip the queues for you because to serve as a motivation to the women who didn't come with their husbands,
I
and
agree.
that goes a long way to help. Yeah. Thank you very much for the opportunity.
Thank you so much, Doctor. Thank you for spending your time with us. Dr. Baba Musa, any last words, any advice for us, please?
You are muted. Patrice, you are muted.
Okay, I'll just add to what Dr. Caesar said. It's actually a good practice or best practice to involve male partners in decision making, and even during the deliveries, you could admit the males as well, so they are always with their partners throughout delivery. I'm sure, Enoch, that awaits you, and that is possible in the Czech Republic where you are.
Yeah.
So we make it possible for their partners to be present during cesarean sections in theater as well. So I don't know, that's from my experience. I don't know the settings in Ghana at this moment. So what I'll add is that a lot of women tend to blame themselves because of stillbirth. They think that they could have, or they would have done something that would have led to them having stillbirth. It is not their fault. What I want to say, if it could happen to anyone, never blame yourself. There are certain things we can prevent. Medicine can prevent certain things. So they are just born to happen. And we try to take them in good faith and hope for the best of luck next time. And yeah, so that's what I'll just add, and I'll make it short so that we can all go home. Thank you. And thanks for inviting me.
Thank you, Doctor. Dr.
Wendy,
Patrice?
Wendy, are you able to? There is a hand up. Can you see it? No, you can't.
No.
I see it. There is Anita. She joined about 15 minutes ago, and she's a public health expert, and I know some of the topics she's very much aware of. I don't know. I know that we've really exhausted your time. I
Yes,
don't know
we
if
have.
you can take that, if you want to take that question, or if you want to take her.
If I want to take Anita?
Anita's question, her hand is up.
Okay, Anita, could you kindly share with us what you wanted to say?
Okay, all right, thank you. So I listened in a bit, but I know I was trying the link earlier on and it wasn't really connecting. But on the male, involving the males or the husband, in theory you would say it, but in reality, in practicality, it doesn't work. We know this, except a few.
The
So
reason being,
now, well, the reason being their own personal issues, probably, or their own preconceived ideas. Now, when you also say that you give priority to women who come with their husbands to the antenatal, I attend antenatals and I see they sometimes do that. And a lot of the women don't like those that don't come with their husbands. Because I won't come at 6 a.m. or 7 a.m. to come and queue. And because somebody came with the husband at 9 a.m., you treat the person before me. Do you get it? So even though we want to involve them, there are single mothers who are pregnant. There are single ladies out there who are pregnant. Even though we want to involve them and carry them along, that move is wrong. I've been to a lot of the classes and I see them and I hear the women complain when I ask them questions. So it is wrong in a way, even though we want to involve the men. Now, when it comes to
Anita,
yes, please.
so I
No, let me address that.
no,
Enoch, if you could
but
kindly let me.
Wendy, before that, I also want us to be, so we're here to solve a problem. We're here to get information that will help to solve a problem. I don't want you to just highlight what is wrong. How do you think it should be done? Because in your talk, in your presentation, you even indicated that the man, it's not even working. And I feel like honestly, it's not just because I am a man or whatsoever. Of course, I told you my wife is in Ghana, I am here, and she goes to antenatal. But I feel like it's an incentive that the system think can better make the men's participation increase. And so, yes, it might not be a perfect intervention, but if let's say it can even raise the men's participation by 10%, by 5%, it's something we should look at. So if you think that is wrong and some women, single women don't like it, what do you think is the best way? I want us to offer solutions and not just present what is wrong and what is not wrong. Yeah.
Oh, of course, that's why I said, yes, in a way, it's good, but it's not like because you're then coming with your husband, you come late and expect your card or your file will be passed before the one who didn't come with, the husband or the father of the pregnancy. Do you get my point?
Yeah.
So that is it. So it's either, make sure you come early if you're coming with your partner or your spouse. That is just it.
So I wanted to address, I wanted to talk about that as well. So it's not just because we want to encourage male participation. You see, you didn't join the conversation early. We've talked about a lot of complications, and then we were talking about the consent form. What Dr. Caesar was concluding on was that, you see, most of the time when Dr. Caesar addressed consent, that's why I'm addressing it from his point of view. when it gets to the time, Anita, you've seen the conversations on my wall, some in my inboxes that I haven't even shared, where the men are not consenting to these cesarean sessions, and some women are sticking by what their husbands are saying. So what Dr. Caesar was saying, that pertaining to consent, if the men were to be involved from the beginning, if they were getting the education that the women are getting from the beginning through all the antenatal services, and so when it gets to the point where the wife needs the cesarean section, then the man would know that, oh, this have moved from A to B to C to D. I've been involved. And we've gotten to a point where it's life-saving for the woman to go through CS. But you see, at a point in time where the man has not been involved, and then just as the person is coming in for labor, we are saying we are not throwing, like we are discussing cesarean session with them, then it feels like, in quotes, a foreigner to the man. So we do it at the hospital, I'll not lie to you. We do it. It's solely to get, when you said why the men don't come, they give excuses. Some are saying it's genuine excuses. Some have to go to work. Some have the luxury of time to maybe spare, depending on what they do. Some are the sole providers and they cannot make it. So what we are saying is that we just want to encourage them. Me, all through my antenatal, my husband was with me every single time. Not just because I wanted priority service, because I was being attended to by Dr. Kwadram. He happens to be my direct uncle. But my husband also worked in the hospital. Aside that, he wanted to be part of the conversation. So we do it. We encourage it just because we want not to look down on anyone, but just so in the long run, we are looking at reducing maternal mortality, and we reducing maternal mortality pertaining to consent, honestly. So it's not just we wanting to be unfair to anyone, but we are looking at the bigger picture.
I get that, but I'm just trying to let us also know, because we are also on the field. You guys are the clinicians, and we ask them the questions. So I just wanted to let it be clear that some of the mothers don't like it. That's just my point. My point.
I do understand. I think it's unpleasant.
Yeah.
If I was in the same position, I would not like it anyway. So it's okay. Thank you very much,
And
Anita.
and then on the other one, let me just cut it short. I think this conversation, like you mentioned, that it has to be done again. The main issues lies more with education and the awareness, because when you talk about maybe what is happening in the clinic, the procedures, how this one came about, seriously, they don't care. They don't. Do you get the point? So because one, the religion, the religious belief, the cultural belief, a woman when she's starting, all those things. So I think it is those myths that we should also concentrate on and create awareness on, because those are the major things that are causing all those. And the men also thinking that they have the power over the women because they've married them. These are the major issues we have as problem, because yeah, she's more like my property. That is the problem.
Okay, Anita, thank you. It's
Thank you.
also obvious that you joined the late, and all
Yeah.
our doctors here address that particular point. So I have the recording I'm going to share, but I agree with you. Actually, one of the points that we didn't address was what she just mentioned, that the men think the women are their property, but that is more
I
cultural.
don't think that is something our doctors can even address.
Exactly.
It's
That
not
is
something they can handle.
that is not
Let's
written.
give Dr. Patrice the opportunities for his last words, and then we give Ines the opportunity for their last words. I think we've
Gerald.
overstretched them, and then we can
Yes.
retire.
Yes, I agree.
I think you are giving me a second opportunity to
Oh,
address.
Oh
yeah, you finished
no, Dr.
yours.
Baba Musa, sorry.
Yes, he did his before Anita. Yeah, that's true.
Sorry. Dr.
So
Musa,
I'm
your last
okay.
words.
That's no problem.
Our Gerald and then Ines? Yeah. Gerald and Ines, yeah.
Yes.
Yeah, okay. So for me, my final word is education. As healthcare providers, we usually get stuck in the chaos of clinical practice and usually don't have time to do a lot of public awareness and education. And so once we don't put the right information out there, people get information regardless. And you
Mhm.
realize that with the influence of social media, there are so many things out there that are not always true. Sometimes as a healthcare provider, you see it and you're like, what are they talking about? It's about time we also do the and all of that. But it's crazy. Like the workload is a lot and we don't get the time to do that. But in our consulting rooms, in our small vital signs rooms, at our nurses stations, anytime we come into contact with people, it's always an opportunity to provide education, to break the myths and to dispel some misconceptions. So public health education is the way to go. Thank you.
Thank you. Thank you. Please, for this particular reason that you gave, I know, and this I don't want to make it personal. Anita is a public health officer, right? I have read Anita on several occasions where I felt like you said she has the genuine opportunity to educate somebody, but her comment was trivialized. And I am not a public health expert. I'm not a doctor by like I am not a medic, and I don't. Baba Musa knows what I do here. But I use the opportunity to bring experts together to enlighten. So it's the education. It's a corporate, something. You are busy minding the clinical aspect, but when we appeal to you, you all made time to help us, especially Caesar, and I appreciate his commitment so much because he was never informed ahead of time. And so I think we can together build a better, a well-informed society. And whenever we have the opportunity to educate, we better educate and use that opportunity, or we may not even get it again, rather than make a trivial comment as if there is a battle between men and women. Gerald.
Okay. Thank you guys for the opportunity once again. I think I really enjoyed the submissions of my other colleagues who presented and the organizers of this program. And I think to make things more clearer, the best way is to prevent these difficulties we are facing and talking about. And that's when those of us in the clinic also get this opportunity, we try and tell the patients based on facts and research. Like people will be asking, I hear you 50-50 doing cesarean section of a mother dying. And I'll tell you the recorded percentages of mortality associated with CS in the developed country is 0.01, but here in Ghana, the recorded one is 0.3%. So sometimes we give them the actual facts for them to know the actual things. We tell them if you have placenta previa and you decide to deliver through your vagina, you have about more than 90% of bleeding to death. But if you do cesarean section for you, you are going to be safe. So we give them the facts, we give them the actual facts for them to know. And that's why sometimes most of them accept. The problem is bringing the men on board. And my facility, we try these women who come to the hospital with their husbands at a particular time. The reason they give is the men have to go to work. If you want to go to work, then it means you come early. So for those who came early, we'll consider those who came with their husbands, and we make it a reasonable people. And I know the male involvement in 6%. Now it's up to like about 16% in one of the government facilities I know, and I think it's helping more. Thank you, and I'll be available for further discussions. Thank you.
Thank you very much.
Thank you very much.
I like this team, including Dr. Caesar, and I will discuss with Wendy, and we can plan another session, and we'll get you informed. Thank you all for your audience. I have the recording. I will make them available later, and you can share and then you can share with your subject. Thank you all once again. God bless you.
Thank you all. Have a good night.
Ah.